Okay, for today we're going to discuss the transfusion therapy and transfusion in your transplantation. So this topic will discuss all about the different blood components and their indications as to where they are being used. And of course here we're going to discuss as well the expected outcome or the incremental increase to each of the unit of the blood when the recipient is being given that particular blood component. So our blood component therapy here or blood transfusion with a component of the blood, we consider this one as just like our drugs or medication because just like our drugs, we use drugs or medication primarily to treat for particular disease. And by doing here your transfusion therapy with your blood component, also try to correct problem related to your blood disorders. And because of that, the same true as with our medications, our component transfusion therapy here would also have some side effects. So we need to be very careful here with the unit of the blood for the transfusion as to the screening and even throughout the process of your transfusion to the patient. Okay, we have here two primary conditions why we are doing here the component therapy. So the first one, we have your, okay, for inadequate oxygen carrying capacity. So for an inadequate oxygen carrying capacity, we are transfusing a unit of the blood in the form of your RBC. That could be your whole blood or even the PRBC. On the other hand, some would be given a unit of the blood because they have problem with the coagulation factors. So most likely what we're giving to them would be the plasma products. So you could have here your fresh frozen plasma. You could also have here your platelet concentrate in the case of your platelet problem. Or you could also have here your cryoprecipitate antihemophilic factor, which are also derived from our plasma products. So we start the discussion with the first blood component. We have here the whole blood. Okay, the whole blood is basically for the transfusion for increasing the entire blood volume, including here the plasma and the RBC mass. Okay, so again, 1 unit of the whole blood is 450 ml. So we are expecting this one that 1 unit of your whole blood can increase your hemoglobin by 1 gram per DL and hematocrit of 3%. But in the case of your RBC aliquot here, so when we speak about the aliquot, so that's 10 to 25 ml of your RBC aliquot na blood. That's primarily for the transfusion of the newborn. So each unit of that can increase the hemoglobin by 2 to 3 grams per DL and hematocrit here by 6 to 9%. Okay, then we have also here the expected increase. So you are expecting that one that the patient or recipient being given by the whole blood are able to reach here the expected hemoglobin and hematocrit level after 48 to 72 hours post-transfusion. So before you try to recheck again for the hemoglobin hematocrit here, so just need to wait for 48 hours up to 72 hours for you to recheck it again to check if the patient, the recipient, has already increased its hemoglobin hematocrit after administration of a unit of the blood. Okay, then we have here the RBC. So we're talking about the PRBC, packed red blood cells. So RBC or red cell, that's your red cell, or you call it one as your packed red cells. So basically that one is for the transfusion of patients which requires an oxygen carrying capacity, primarily increasing here the RBC mass only, not the volume component, or not the plasma component, but the RBC mass. Okay, so basically your PRBC, the volume for that could be 200 to 250 ml. So if that one has been collected from your AC, DCPD, CPD2D, or if the blood has been collected with an additive solution, then it would have here the volume of 165 to 270 ml. Okay, then we have here the patient's manifestation that requires here to be given a PRBC. Number 1, we have your pulse rate more than 100 beats per minute. We have also your respiration rate more than 30 beats per minute. The feeling of dizziness, the feeling of weakness, angina, and difficulty of thinking that would signify that the patient would have a decrease in oxygen mass. Okay, we have here, for correcting this one, you can increase the plasma volume, you can increase the heart rate, respiration rate, and oxygen saturation. or oxygen extraction. Okay, when are you going to give here your PIBC? So, for some patient, 6 grams per DL is already require the patient to be given a unit of your PIBC. But I think the consensus committee of the blood transfusion requires that one to be 7 grams per DL. And for those patients having a cardiac problem, so they should be given the PIBC here when their hemoglobin is 8 grams per DL. Okay, contraindications. So we are not transfusing the PRBC for the following conditions. Number one, as a treatment for your well-compensated anemia, like in the chronic renal failure. Second one, we are not transfusing the PRBC for your nutritional deficiency anemia. Like for example, iron deficiency anemia can be corrected by administration of the iron, not by your PRBC. Or folic acid deficiency anemia can be corrected by administration of folic acid, but not by your unit of the blood. Another one, we are not also transfusing this one just to promote your well-being, not for aesthetic value. And the fourth one is not only also here for the wound healing. Okay, the next blood component we have here, the leukoreduce. Okay, the leukoreduce RBC here is eventually being prepared by the leukoreduction process by allowing that one to be filtered here through your allowing the removal of your WBC through your third generation filter. The leukoreduced RBC here would eventually try to prevent the following. Since this product wala ka ng WBC or WBC has been reduced, so eventually this one is used here for the prevention of number one, febrile non-hemolytic transfusion reaction, primarily caused here by your biological response modifier. We have also here prevention of your HLA, allo immunization, because that one could also be found on your WBC. And even it can also prevent here your cytomegalovirus transmission because the cytomegalovirus here try to reside on your WBC. Okay, so each unit of the whole blood contains here 2 times 10 to the 9 na WBC count, but after your leukoreduction process, ang WBC count natin should eventually be, ganito na lang siya dapat. Ang matitira, 5 times 10 to the 6. Okay, next one, we have your cytomegalovirus negative blood components. So, your leukoreduce, okay, primarily to prevent your cytomegalovirus transmission. Because again, your cytomegalovirus try to reside on your WBC, specifically on your neutrophil and monocyte. It's also given also for the pregnant patient to prevent also that to prevent here the cytomegalovirus reactivation. Another one, we have your WASH, RBC, frozen deglycerolized RBC. So by having this frozen red blood cell here, we can only utilize this one after your deglycerolization process where we try to subject that one to your decreasing concentration of your saline solution. So by washing step, you tend to remove your plasma proteins. And the plasma proteins are the one causing here your allergic reaction or anaphylactic reaction. So by washing step, this wash, RBC natin, can prevent your anaphylactic reaction or anaphylaxis reaction or your allergic reaction. Okay, the next one, we have here your platelet concentrate. The platelet concentrate is indicated primarily for patients having the thrombocytopenia. Okay, we can prepare your platelet concentrate. We have your thrombocytopenia may be induced by your chemotherapy and the DIC or even your massive transfusion. So we have your 2 types of your platelet concentrate. One is your random donor. That one can be prepared through your component preparation by subsequent light spin followed by your heavy spin. And we have also here your single donor na platelet concentrate that's being prepared through your apheresis. Quality control. Okay, your random donor should contain here 5.5 times 10 to the 10th na platelet count. And 1 unit of your random donor platelet concentrate can eventually try to increase the platelet count of your recipient by 5 to 10,000. For the single donor, on the other hand, quality control, that one contains 3.0 times 10 to the 11 the platelet count, and each unit of that can increase the platelet count by 20 to 60,000. You can also pull here your platelet by having 4 to 6. The single donor, try to combined at 1, and that will be equivalent to your single donor. So your pooled platelet concentrate here can also increase your platelet count of the recipient by 20 to 60,000. Okay, the expected incremental increase here is being manifested after 10 minutes to 1 hour post-transfusion. Okay, we have here the term platelet refractoriness. So this is a condition wherein the patient's platelet or recipient's platelet count did not increase after your administration of your platelet concentrate. So bakit din siya nag-increase? It might be immune-mediated because the patient has anti-platelet antibody. So even if you try to transfuse the patient here with a platelet concentrate, so since the patient would have an anti-platelet antibody, it tend to destroy the platelets coming from your donated blood. Or non-immune may be related to your number 1 because of your splenomegaly, because remember that your spleen try to sequester our platelets. Another one may be related to your DIC or even in your sepsis and even your fever. Okay, then we have here the formula for the evaluation of your transfusion related to the platelet concentrate. Okay, we have here for the random donor, the formula here for you to check if the recipient has reached the expected increment or hindi. We have here the post-transfusion platelet count minus the pre-transfusion platelet count of the patient. Multiply that one with the body surface area of the patient in meters squared over the number of the units transfused to the patient multiplied by 0.55. On the other hand, for the single donor, so it would have still na same formula, only that magkaiba lang kanilang factor. So that's your post-transfusion platelet count minus the pre-transfusion platelet count multiplied by the body surface area of the patient meters squared over the number of the units transfused multiplied by 5, multiplied by 3. So based on this computation, so dapat ang increase mo dito ay again pag random donor should be between 5 to 10,000. For your single donor should be between 20 to 60,000. If for example mababa the expected increase mo dito after you try to perform the computation, then again you go back, it may be because of your refractoriness or platelet refractoriness. For the next one, we have your granulocyte concentrate. So this can be prepared here by your apheresis program. So granulocyte concentrate is for the increasing the neutrophil count of patients, especially for patients having the neutropenia or neutrophil count less than 500 per UL, and the patient is unresponsive to the medical treatment, where the patient has septicemia, where the patient has bacteremia, and the patient is no longer responding to the antibiotic treatment and would have here the neutrophil count less than 500 per UL. So, pag baba na ng neutrophil count na, so wala ng protection ng kanyang katawan against your microorganism, and therefore you need to be given here your granulocyte concentrate. Another one is also being given for the patient having reversible bone marrow hypoplasia, and of course here, neutropenia pa din related also to your chemotherapy. Each unit of your granulocyte concentrate contains 220 ml, and that will being given primarily for adult population or for children is being given here 1 unit for 4 consecutive days, so that's almost 4 units. And for the infants, just have the portion of your granulocyte concentrate. Okay, just give once or twice. That's already enough to increase the neutrophil count of the patient. 1 unit of your granulocyte concentrate contains 1 times 10 to the 10th na WBC count. So that's already high because again, granulocyte concentrate should have high concentration of your WBC because we wanted to correct problem with your neutropenia. On the next one, we have your fresh frozen plasma. The fresh frozen plasma here contains all coagulation factors. That's 400 milligrams of your fibrinogen and 1 unit of all your stable clotting factors. And therefore, we tend to use the fresh frozen plasma for the following. Number 1, for patient having multiple coagulation factor deficiency. Because again, your fresh frozen plasma or plasma, normal plasma contains all the coagulation factors. And therefore, it can correct if the patient would have a multiple coagulation factors deficiency problem like in the liver disease. In your vitamin K dependent coagulation factor deficiency, your factor 2, 7, 9, 10, protein S, protein C, protein Z deficiency can be corrected also by administration of your fresh frozen plasma, or even for someone having the massive hemorrhage that eventually may allow the patient to be prone here for the bleeding manifestation. Okay, so dosage here, 4 to 6 unit, 220 ml should be given for the patient having the liver disease and the DIC. But for example, you may need here an additional na unit of your fresh frozen plasma if, number one, if the prothrombin time result here is more than 1.5 times than the normal na prothrombin time, or even the INR result na more than 1.5. So, pag ganito result the patient still have the tendency to bleed, and therefore you need to give your fresh frozen plasma. Okay, contraindication, again, your fresh frozen plasma is not used for increasing the plasma volume. For increasing your plasma volume, you can use your mga volume expander, plasma volume expander natin, like your NSA, your protein, purified protein derivatives. Not this one, not your fresh frozen plasma. Okay, the next blood component we have here, the cryoprecipitate. So the cryoprecipitate represent here the precipitated thawed the fresh frozen plasma, which represent here the precipitated protein component of your precipitated protein component of your frozen na fresh frozen plasma natin after it undergone here your thawing process. Cryoprecipitate is needed primarily for the treatment of your fibrinogen deficiency, including your von Willebrand disease. Okay, we have here the constituents of our cryoprecipitate. So factor 8 contains here 80 to 120 unit, fibrinogen concentration 150 to 250 milligrams. Factor, von Willebrand factor is 40 to 70% of the original na fresh frozen plasma natin. And the factor 13 is 20 to 30% of the original na fresh frozen plasma. Factor 8 concentrate is a type of your plasma derivatives. That one is primarily for the treatment of your hemophilia A. This is a plasma derivative, so it's undergone here purification steps and even your viral inactivation, either by pasteurization, nanofiltration, or even solvent detergent, making this one as less infectious. Okay, less likely to transmit your viral infection because it tried to undergone a processing with a different method for your viral inactivation process. We could also have here your recombinant human products which are purified, like your factor A concentrate, which is purified one, so for the treatment of your hemophilia A, or factor 9 concentrate for the treatment of your hemophilia B. So we have here the computation for the number of the unit of the cryoprecipitate for the patients. Okay, that eventually should be given to the patient. Okay, so this one is for your fibrinogen. Okay, we have the given for that weight of the patient 65 kilogram, hematocrit is 0.28, initial fibrinogen levels 32 mg per dl, expected final fibrinogen is 100 mg per dl. So currently, ang patient natin, ito pa lang kanyang fibrinogen at gusto ng physician natin that will try to increase that 1 to 100 mg per dl. So how much of the cryoprecipitate are you going to give to the patient? So we have here the formula. First, you need to compute for the estimated blood volume. Estimated blood volume here is computed as the weight of the patient. So that's your 65 kilogram. And we have here the factor for your blood. That's already a standard na value. That's 70 ml per kilogram. So our result natin dito is 4,550 ml. After you compute your estimated blood volume, we're going to compute here for estimated na plasma volume. Estimated na plasma volume is taken here as your estimated blood volume. Multiply that one with 1, the difference between the difference of 1 minus the hematocrit of the patient. Only that you need to present that one in liter per liter, since this one is already liter per liter. But if you have your percent, so just need to move that one to decimal places that become here your liter per liter. And for this one, our result is 3,276 ml. Next one, try to compute here for the amount of the fibrinogen needed para ma-reach natin ang 100 mg per dl, which is the expected na final fibrinogen concentration. So our formula for that, we have the final fibrinogen concentration, 100, minus your initial fibrinogen, that's 32 mg per dl. Multiply here by your estimated na plasma volume. But then again, since ang value nito ay mg per dl, we need to convert that one to your mg per ml. So, i-divide natin ito by 100. So, ito ay magiging 1 mg per ml. 32 natin, divide natin by 100, that's 0.32 mg per ml. Multiply by our estimated plasma volume. So, ito na yun. Okay, itong kailangan natin na fibrinogen, that's 2,228 milligrams of the fibrinogen should be given to the patient. How much of the vial are you going to give to the patient? How many vial are you going to give? So, ang vial natin ng fibrinogen, maybe one vial could be in the 150 milligrams, the other one is in 250 milligram, or one cryoprecipitate, sorry, not vial, but cryoprecipitate. One cryoprecipitate unit can contain 150 milligrams of your fibrinogen, or one cryoprecipitate unit can also contain 250 milligram. So, kung 150 milligram ang content ng ating cryoprecipitate, so ito magiging formula natin. So, this is your amount of the fibrinogen needed para ma-reach ang ating final fibrinogen. Okay, multiply by 1 unit. So, 1 unit mo ay 150 lang na milligram. So, that's 14.9 na unit ng cryoprecipitate should be given to the patient in order for that to increase the fibrinogen niya from the initial na 32 mg per dl para ma-reach natin ang 100 mg per dl. What if, for example, your cryoprecipitate contains 250 milligrams of your fibrinogen? So, ito magiging formula natin. We have the one here. So, this is your amount of your fibrinogen needed multiplied by 1 unit over 250 kasi 1 unit mo ng cryoprecipitate contains 250 milligrams ng fibrinogen. So, that's 9. 9 units should be given to the patient if your 1 cryoprecipitate unit contains 250 milligrams of your fibrinogen. Okay, the next blood component we have here, the irradiated whole blood. Irradiated whole blood is prepared here by subjecting this one to your gamma radiation, 25 GY gamma radiation at the center, and 15 GY on the other part of the blood. Gamma radiation here with irradiation process tend to destroy your immunocompetent T lymphocytes. Immunocompetent T lymphocyte found in your unit of the blood, responsible here for the rejection of the tissues or even the blood of your recipient. Okay, so we have here the factors for the graft versus host disease. So primarily the irradiated blood is for the prevention of your transfusion-associated graft versus host disease. So we have here several factors why you try to develop here your graft versus host disease. Number one, there's a presence of your immunocompetent T lymphocytes present in your unit of the blood or even in your transplanted tissue. Second one, the difference, HLA difference between your recipient and the donor also try to affect. The more different they are, so the higher the chance of graft versus host disease. Third one, immunocompromised recipient, wherein the patient here try to tolerate the presence of the immunocompetent T lymphocyte coming from the transplanted tissue or blood unit. And that transplanted na immunocompetent T lymphocyte would be responsible here for the destruction of the unit of the blood of your recipient or even the tissues. Okay, we have here the patients at risk for the development of transfusion-associated graft versus host disease. Number one, immunocompromise. Again, pag immunocompromise ang patient, the patient itself, immune system niya, ay hindi niya pinapatay ang immunocompetent T lymphocyte coming from your donor. And therefore, just allow your immunocompetent T lymphocyte to proliferate in his circulation and recipient. And that's responsible for the destruction of the patient's own tissue or even the patient's own blood. Another one, intrauterine transfusion of fetus, exchange transfusion of neonates, and another one would have here the donation from your blood relatives. Pag blood relative, it will have your transfusion-associated graft versus host disease because here that since you are relative, one haplotype ng HLA natin usually are matched with your recipient. So, pag match sila, pag nag-transfuse ka ng blood, usually kasi dapat pag nag-transfuse ng blood, pag ang host immune system natin ay very active, it tend to destroy your immunocompetent T lymphocyte coming from your transplanted tissue. Pero ito kasi, nakita niya ay hindi niya ma-recognize na foreign ang substance or yung blood ang transfuse sa kanya is because here, 1/2 of his haplotype are same with the donor because they are blood relatives. And with that, anong gagawin niya? It will just let the immunocompetent T lymphocyte proliferate in his circulation. And pag ando na ang immunocompetent T lymphocyte in his circulation, that will be going to destroy his own tissues or his own na mga RBC. Another one, HLA match platelets. Okay, now we go to your transfusion in your transplantation. So we have different types of your transplantation. Autologous, the donor recipient are just the same individual. Allogenic, so you have the donor recipient are two different individuals. And genetic would be among twins. And xenogenetic here would be transfusion of the unit of the blood or transplantation of the tissue coming from the animals to the human. We have here the match. Pag ang donor sa recipient ay magkapatid, 25% of that entire HLA are match. 50% one haplotype is match and 25% mismatch. Pag parents, okay, so ang donor natin parent, ang recipient is the anak. So 100% match one of their haplotype because the offspring, we try to inherit our haplotype, one from your mother and one from your father. So pag a father ang donor, tapos ikaw recipient, so half no ng haplotype mo ikapareho si father mo because half of that ay galing kay mother. Okay, then we have your hematopoietic progenitor cells. Okay, so hematopoietic progenitor cells or stem cell transplantation can eventually be needed for the following. For patient having the bone marrow problem, including here your Hodgkin lymphoma, or even for this patient with the acute or chronic leukemia. Okay, we have here different sources of your hematopoietic progenitor cells. You can have here your, number one, we have your bone marrow. You call this one your HPC, M or the marrow. Another one, you could also have your WBC or your peripheral blood. That's called that one as your HPCA for apheresis. That's a method of collection. Another one, your HPC C. So your cord blood could also be the source of your hematopoietic progenitor cells. For the first one, hematopoietic progenitor cells marrow. So the bone marrow is being collected through your aspiration technique. So most likely, try to aspirate that one to your iliac crest. Approximately 10 to 15 ml of the bone marrow is being aspirated. Okay, we have here the risk factor for the bone marrow aspiration. Could have your pain, bruising, or nerve damage. Another one, we have your HPCA for apheresis for your WBC, peripheral blood. So for that, you just need to increase first the WBC count of the patient by giving him your hematopoietic cytokines in the form of your granulocyte monocyte colony stimulating factor or granulocyte colony stimulating factor that will increase the WBC count of the patient. Then after 5 to 6 days of administration of that, that's the only time you're going to collect your peripheral blood. You are expecting that one to have already an increase in WBC count. But we have here the marker, CD34. Okay, this is a marker for your WBC. This is actually the marker of your hematopoietic progenitor cell or hematopoietic cell natin. So we start with administration of that 10 microliter lang. Pero ang pinaka-target natin, before you try to harvest your hematopoietic cells, you should reach here 2 to 6 times 10 to the 6. Another method for your hematopoietic progenitor cells here, collection would be the cord collection, your cord blood na collection. This one is being collected after the delivery of the baby. That's after the placenta. That's after the umbilical cord has been clamped and after or even before the delivery of your placenta. Okay, for that one, you'll be needing here 100 ml of your CD34 containing 1.5 times 10 to the 5 cells. Okay, so we have your consideration for the cord hematopoietic progenitor cell transplantation. So you need to check for both the mother and the baby for some genetic diseases. Another one, you should also check here for the AB1RH for both the infant and for the mother And you'd also check here for the antibody screen for the mother. Okay, processing. When you're collecting your bone marrow, you need to filter that one to remove here your bone specules, your fats, or even your debris. For your peripheral blood, you only need to do is just centrifuge that one and collect here only the buffy coat, because in the buffy coat is where you can find your WBC. It's where you can find your hematopoietic progenitor cells. Okay, then the better way of centrifugation of that, collecting much of the buffy coat, is by adding your sedimenting agent in the form of your ficol, dextran, or even your hydroxyethyl starch. So you can transfuse this prepared natin na hematopoietic progenitor cell freshly, or pwede din siya, you can store it at 20 to 24 degrees Celsius here for 24 to 72 hours, or at 4 degrees Celsius. On the other hand, you could also frozen at -80 pag hindi mo pa siya ita-transfuse. Okay, and you can add prior protective agent for that before you try to frozen that one. Prior protective agent, you can use your 5 to 10% dimethyl sulfoxide or DMSO. You could also use here your hydroxyethyl starch before you try to frozen that one at -80. Then we have here your solid organ transplantation. So it's transplantation of your different organs or tissues. So we have here the lungs. It's the most stringent one because this one would have a lesser chance of survival or success in the transplantation. So medyo mahirap ang lung transplantation natin. Usually it tend to collapse. At medyo strict sa criteria between the donor and recipient. For your kidney and pancreas, most likely this one less susceptible to your ischemia, and most likely that one do not require a unit of the blood for the blood transfusion. Our liver is the one trying to require here most of your blood transfusion, requires massive unit of the blood to be transfused. Okay, so usually liver transplantation is being done here if the patient would have abnormal coagulation factors. And most likely you tend to transfuse 10 to 20 units of your PRBC, or even 10 to 20 units of your plasma if the patient's undergone a liver transplantation. So we have the plasma consideration. The citrate present in your anticoagulant here would eventually try to be metabolized by our liver. An increased citrate would tend to result to your hypocalcemia, and that results to your deterioration of your heart functions and heart conduction abnormalities. Portal hypertension would have put the patient here at risk of higher bleeding manifestation. Then we have here our soft tissues. Then you can have your bones, you can have your cornea, skin. So usually you have your cadaveric donor, so mean to say dead na siya or about to die. So except here for the cornea and skin tissues where eventually that one has been collected already and being processed and sterilized and for sale in the hospital for that. Okay, so that's the end of our transfusion therapy. Okay, thank you.